Okay, this is part 2 of chapter 7, and we will continue to discuss assessment needs, functional assessment of geriatric patients. First of all, to collect history is not always possible from a patient him or herself, so we need to ask assistance and ask questions from family members. But you have to take into consideration that if the geriatric patient and a family member live together, he or she might be more knowledgeable and more able to detect changes in the level of consciousness or condition. But if a family member lives far away from the geriatric patient, the further the family member lives, the more dependent the geriatric patient might look like in their eyes. So frequently when I receive a patient to post-acute setting, to rehabilitation center from an acute care setting, and I discuss patient condition with the relatives, the daughter or the son, I frequently might hear, I don't know how this happened. Just yesterday my dad or my mom was able to go to a grocery store, do some shopping, do some cooking. They were pretty independent. They didn't need a caregiver. So what happened? Over the time when you didn't see your parent, maybe you called once in a while, everything in your eyes looked good, but you may not detect little changes that can happen with, for example, UTI development. And symptoms of UTI in elderly patients are different than with younger. And the first sign is a change in cognition. They might eat not as good as before. They might be more confused and not complain of dysuria. And these little things you can notice if you live in the same environment with the geriatric patient. That's why direct observation, close monitoring is much better than just collecting subjective information. So during your assessment, ask questions how an elderly individual performed a task, rather than asking closed-ended questions. So ask to explain, for example, from the beginning, how do you perform certain activity, how do you take a shower, and then ask if the activity is meaningful to the elder. Next is evaluation of the living environment, and this is also a very important part of assignment that a registered nurse or an LVN later also is doing. Because at home health agencies, nurses, RNs, and LVNs are working. Usually a case is opened by an RN, and later on an LVN comes doing necessary interventions like insulin administration or wound care. It depends on what a patient needs. So the first visit you do evaluation of the environment. What you look for? You look for clutter on the floor. You look for sufficient warmth or coolness of the apartment or the house. You look if the temperature is adequate in the refrigerator, so the food will not become bad and rotten. So all this taken into consideration, as well as the use of assistive devices and equipment. For example, with my students, I used to come to do a house call to see a patient, and she was above knee amputee, blind individual who was bedbound because of stroke. And she had a caregiver 24/7, so she lived at home. When we came inside of the bedroom, what I saw, it was a queen bed, and the patient was in bed, so she required a repositioning. What the caregiver did, she stood up with her feet on the bed just in front of us, me and students, and she came to the back of the bed, grabbed the patient under her armpits, and started pulling her up to make her in more sitting position. Is this intervention appropriate? No, absolutely not. What does this patient need? She needs hospital bed, and this is an absolute necessity. So we return back to the office, and we discuss this with the social workers. So the primary care physician will be contacted all necessary paperwork filled, and the patient will receive the equipment that she needs for safety. Take a look at this picture. Having children is, from one hand, is very beneficial for elderly patients, especially psychologically. They provide positive stimuli for elderly patients. We used to go to One Generation adult daycare center, and they have daycare for geriatric patients, and next door is kindergarten. And they frequently, it was before Corona era, they frequently brought children to communicate with elderly patients, and I believe this interaction was very effective and beneficial for elderly clients. It's what I was able to observe. So same as at home. Living with extended families, from one hand, provides greater care, but take a look at this on the floor. Even if toys are located in baskets, they can be spread all over the room within few minutes. Kids can do it really quick. So this floor is very dangerous for geriatric clients. So this also has to be addressed. Next, we will discuss proper use of assistive devices, mobility devices such as a cane, and also we will discuss, because this can be on the legs, with which leg a patient needs to go up and down the stairs. In terms of assistive devices, in class I usually ask students a question. For example, a patient with total knee replacement with a splint on the right knee, unable to, restricted to bend his knee, doesn't want to take a bed bath. How we will manage the situation, how we will assist the client to take the bath. So shower chair is not appropriate because it's only safe for the patient to sit inside. But to step inside of the bathtub is dangerous because of balance and risk of falls. So what to do in this situation? A shower bench is the solution. As you can see, two legs located outside of the bathtub, it's where the patient sits and just propels him or herself to the right in the bathtub. This is the safest equipment that can be used and provide more independence. The patient can take a shower maybe on his or her own with minimal assistance, and doesn't require a bath. Shower. Bed bath. Next, we also have to pay attention how correctly or not an individual, especially elderly individuals, use adaptive equipment. And a cane or a walker are examples of this. Frequently, I notice the tendency if a person has a bad leg, like right bad leg, he or she will grab a cane on the right side. But this is not correct. And take a look here. We have two legs to keep our balance, not to fall. In case if one leg is weak, like we have it here, right one, we don't need the cane on the right side. We need it on the left side. So what happens? At the time when the good leg does not support the weight, and it's only the bad weak leg, so the fall risk is greater, we need an artificial leg on the opposite side, and this serves the cane. So the cane is supposed to be on the opposite side from the bad leg. In this case, this is the right lower extremity. So at the time when the right lower extremity is on the floor, partial weight is also supported by the cane. And when the good leg stands up, then the balance can be achieved, and bad leg and the cane working together. So pay close attention how your patients use adaptive equipment. Next, going up or down the stairs. It's always confusing and difficult to remember, maybe to memorize what we put first, good leg or bad leg, going up, down, or down the stairs. So, when I was a nursing student, my instructor told that I will tell you a story that is easy to remember and you will never confuse which leg to put first. She said that over there is heaven, it's good. Over there is hell, it's bad. So, going up, we put first the good leg. Going down, we put first the bad leg. And this picture shows this. As you can see, the guy with the bad leg, that is left lower extremity, he puts first the right lower extremity going up and puts down the bad leg when he goes down. What are goals of functional assessment? First of all, we cannot cure diseases, multiple diseases that a general patient might have, but we can promote quality of life, promote independence, and minimize disability and their functional loss through early identification. Our treatment plan has to be based on their functional performance to enhance their functional capabilities now and improve the deficiencies. Our goal is to maximize quality of life. You have to maximize first and concentrate on what limitations the individual has first and ensure compliance. And determine efficacy of treatment modules by measuring changes in functional performance. So you have baseline information and then you compare and do evaluation periodically if there is any improvement in health status and what changes to your plan might be needed. Keep in mind that you are not working alone, you work together with physical therapists, occupational therapists, registered dietitian. Whole team is available to reach your goals. Activities of daily living. Activities of daily living are essential to determine what level of assistance for personal care is necessary. Deficiency in one or more area of activities of daily living requires a 24-hour support. Keep in mind, this is not 24-hour nursing care. It's a 24/7 caregiver. A person who is unable to feed himself and to take a shower without assistance needs 24-hour support, but it's not necessary in nursing care. Nurses have skills that is directed to care of special needs, such as tubing feeding, IVs, wound care, what a caregiver, regular caregiver, cannot provide. So you have to delegate responsibilities based on educational level and safety, that is safe to do for a patient. ADLs, activities of daily living, include bathing, dressing, toileting, transferring, continence, and feeding. If a patient is incontinent and unable to dress without assistance, for example, and take baths without assistance, in this case, he or she might need 24-hour care, but not nursing care, a caregiver. This can be accomplished at home with live-in caregiver, or assisted living facility, or boarding care facility. And CAT Index of Independence in activities of daily living is a tool that we will use for evaluation of the patient needs in activities of daily living. You will be given a short case scenario that you will use. Each 1 point is given for each section, and then you will calculate and be given a score. Based on score, you will determine the level of care necessary. This concludes part 1 of chapter 7. Part 2 is coming. Part 3 is coming.